Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all lecturers, doctors, ladies and gentlemen. Welcome to today's breakfast at UMHealth webinar. I, Dr. Aiman bin Hamid from the Department of Otorhinolaryngology, Head and Neck Surgery, UMMC, will be one of the moderator for today's talk. But before we begin, I would like to remind the audience to please mute your microphone. This is to ensure the event goes smoothly and to avoid distraction. If you have any question or inquiry, you can type it in the message section or can ask after the presentation. Okay, let's get to our first talk today on the common misconception of sinus problems, allergic rhinitis versus chronic rhinosinusitis, which will be delivered by our first speaker, Dr. Andrew Charles Gomez Jr. A little bit of background information regarding Dr. Andrew. After completing his undergraduate training, he received his MRCS ENT from Royal College of Surgeons, Edinburgh in 2015, and he completed his master in otorhinolaryngology, head and neck surgery in 2021. Since then, he has devoted his career in UM as a medical lecturer and ENT head and neck surgeon. Currently, he is doing his fellowship in rhinology and anterior skull-base surgery, practicing in the rhinology unit of the otorhinolaryngology department in UMMC. Without further ado, I would like to call upon Dr. Andrew to give his speech.
Okay, so today we're just going to have a brief overview as to what are the common misconceptions regarding allergic rhinitis and chronic rhinosinusitis, because very often in clinical practice, we have patients who come in to us, or relatives or family members who come into us and tell us that they've got sinus issues. Now, as a doctor, we should gear ourselves up for these discussions because it's fairly common, and we also should equip ourselves with a little bit of knowledge into what it is to actually have sinus issues and what it is to have allergic rhinitis issues, which is actually more common. Yeah. So during this brief topic, we will define what allergic rhinitis and what chronic rhinosinusitis is. We will discuss the risk factors and the pathophysiology. We'll highlight some of the key diagnostic and clinical differences and emphasize the importance of accurate diagnosis as well as management. Now, for the overview of rhinitis and sinusitis, we will do a brief introduction to rhinitis and sinusitis, and of course, more importantly, to distinguish the difference in clinical practice. Okay, now let's have a look at what these two entities are. Allergic rhinitis is an IgE-mediated hypersensitivity of the nasal mucosa causing inflammation. Now, the reason why it is not called atopic rhinitis, like how atopic dermatitis is because atopy is a term that is used to define IgE-mediated inflammations only. However, in allergic rhinitis, we have what is known as an early phase and a late phase. When a person is exposed to any allergen, they will initially have the first symptoms of running nose and nasal itchiness that will last 30 to 45 minutes. After that, that slowly subsides. But what happens later on is after about 3 to 6 hours, there is a late phase, which is actually more pronounced symptoms. Now, because the late phase is mediated by cellular mediated hypersensitivity, which is type 4, it combines actually two types of allergy of hypersensitivities. Therefore, the term allergic rhinitis is often used. Now, the cardinal symptoms for both allergic rhinitis and chronic rhinosinusitis is nasal discharge and obstruction, but there is where the commonality usually ends. Yeah. For allergic rhinitis, they will be associated with irritative symptoms like sneezing, runny nose, epiphora, can sometimes have cough. And nasal itchiness can also be there. So these are the more irritative symptoms. Whereas in chronic rhinosinusitis, because of the chronicity of it, it generally leads to nose block and running nose, yes, but it also leads to facial pain or congestion, and it can lead to it can lead to facial pain, congestion, and reduced smell, hyposmia or anosmia. Yeah. Now, with chronic rhinosinusitis, by definition, because of the chronicity of it, it should generally last for more than 12 weeks. Yeah. Okay. So as we can see from this pretty busy slide, the only thing that I wanted to highlight was allergic rhinitis is actually a lot more common than chronic rhinosinusitis, generally by about 5 to 6 fold sometimes. Yeah. So risk factors for developing allergic rhinitis, because it is part of what is known as the allergic or the atopic march, yeah, which starts with contact dermatitis, lactose intolerance, then leads to things like allergic rhinitis and asthma. There is a family predisposition for this. Environmental triggers like pollen, dust mites, animal dander, as well as mold are also risk factors for developing allergic rhinitis. In a highly urbanized area or where there's a lot of pollution, also is a risk factor, and early exposure, which leads to what is known as the hygiene hypothesis. Um, Chronic rhinosinusitis, on the other hand, is, as mentioned, it's a chronic manifestation of rhinosinusitis, which is inflammation of the nose, of the mucosa of the nose, as well as the sinusitis. What contributes more towards the development of this chronic rhinosinusitis is an outflow obstruction, whether there's anatomical issues like a deviated nasal septum or there's a polyp, and this can block the outflow obstruction of the sinuses, leading to inflammation. Of course, in acute rhinosinusitis, most of the time it's due to infections like bacteria, viral, and fungal. And if the outflow obstruction is obstructed, it starts a vicious cycle, which leads to eventually a chronic obstruction. Yeah. Environmental factors as well as systemic disease also play a particularly important role in chronic rhinosinusitis. Now, allergic rhinitis, again, IgE-mediated type 1 hypersensitivity. This is mainly for the early phase. And then for the late phase is mainly by eosinophilic infiltration. What about chronic rhinosinusitis? Since allergic rhinitis is mainly an allergy to an allergen, chronic rhinosinusitis, on the other hand, is in recently in the EPOS, the European position on sinusitis, they've gave it more of an academic classification, leading with the discovery of T helper 1 and T helper 2 cells, which cause inflammation. So just a little bit of background history. Previously, there was a lot of theories as to why people developed chronic rhinosinusitis. One of it was because they thought it was initially a bacterial infection. So the treatment for that used to be prolonged antibiotics. Then they came into the Staphylococcus super antigen theory, which they thought that there was Staphylococcus produced a super antigen that caused this chronic inflammation, therefore leading to sinus problems. Again, that was not really true because we couldn't, antibiotics just didn't completely resolve all the issues. Then they went into, at one point, into fungus. They thought fungus is the cause. So, opening up all the sinuses with proper control of the humidity as well as the aeration would lead to a better sinus clearance. Then they thought that it's actually all the patient's fault because the host just had a weird immune system which reacted towards external things and caused the sinuses to get clogged. However, as of now, this is the current theory. It is a complex interaction between the environment and the host that leads to a barrier penetration of the immune system, leading to a endotype. Endotype would be the type of inflammation, eventually leading to some sort of remodeling of the immune system, manifesting later on as a phenotype, whether it is asthma, allergy, or chronic rhinosinusitis. These are all phenotypes of the endotype. Yeah, I hope that makes sense. Sorry. Okay, so symptoms-wise, we have established that the symptoms of allergic rhinitis they are accompanied with irritative symptoms, whereas in chronic rhinosinusitis, more of chronic symptoms like facial pain and reduced smell. Of course, in allergic rhinitis, some types of allergens only present themselves in certain seasons, while others are continuous throughout the year. So that divides them into seasonal and perennial types. And physical examinations, basically physical examination performed can point the clinician into the right direction. Okay, so when we do our physical examination, generally a patient with allergic rhinitis has a tendency to rub their eyes. So they can have this post-inflammatory hyperpigmentation around the eyes. They can even have what is known as allergic salute because they keep pushing their nostril upwards. their nose upwards, and that creates a line over the tip of the nose, right? And even at the side of the nose, they can have this shyness, which also a hyperpigmentation, basically because of chronic irritation and chronic rubbing of the nose. Now, in chronic rhinosinusitis, generally speaking, there is no external pointing. There is no stigmata that points towards chronic rhinosinusitis, apart from probably a mouth breather. Now, when we look inside the nose, of course, we are all familiar with turbinates. Turbinates are the fleshy nose that protrude, the fleshy part of the nose that protrudes into the nasal airway, which you can see if you just look into the mirror and lift up your nose. So we've got three turbinates. One is in the bottom, the other one is in the middle, and the last one is at the top. Now, when we look at this turbinate, this is how a normal inferior turbinate should look. Okay, this septum is slightly deviated, but this is how a normal inferior turbinate should look. In a patient with allergic rhinitis, this is what is commonly seen. It's a mildly enlarged, moderately enlarged, or markedly enlarged inferior turbinate, almost occluding the whole entire nasal passage. This is particularly important to note because it is a clinical sign that can differentiate between whether you're dealing with allergic rhinitis or chronic rhinosinusitis. Some patients have both, but majority of the patients will have either a predominant allergic component or a predominant chronic rhinosinusitis component. Whereas in chronic rhinosinusitis, on the other hand, this is the middle turbinate. This is slightly higher up in the nose. Now we see that this polyp is protruding down into the nasal cavity here. This is a polyp. Okay, it's a semi-translucent protrusion of the submucosa through a breach in the mucosa, and it is actually not a tumor because it does not show any mitotic activity. It's actually just a protrusion because of the break in the skin, in the first skin layer, and it's filled with inflammatory mediators. Again, this is in response to a chronic irritation. Now, sometimes, so there's two main clinical entities which we can differentiate endoscopically, especially when we've got a pathology that is confined to the middle meatus, which is the point between the middle turbinate and the inferior turbinate. They can either have a polyp, or they might not have a polyp, but they will have very thick mucus within this area. This thick mucus also is indicative of chronic rhinosinusitis, and in that case, it would be without a polyp. Okay. Now, diagnosis. So again, history, physical examination is paramount to pointing us in the right direction. And I also wanted to talk a little bit about investigations in both allergic rhinitis and chronic rhinosinusitis. Now, in allergic rhinitis, usually the differential diagnosis of a patient with allergic rhinitis is, of course, non-allergic rhinitis. In cases where there is no allergen that you can identify either with physical examination, a skin prick test, or a blood test with RAST, radioallergosobin testing. If in the absence of this, then you can safely say that this is non-allergic rhinitis. But if it is allergic, then we have to prove that the patient has got mounts an allergic reaction towards something in the environment. So that can be done with history, which is usually adequate. Or if there's nothing in history, then we can proceed with a skin prick test. Of course, the gold standard for diagnosing allergic rhinitis is actually what is known as a nasal provocation test. But as you can imagine, introducing allergens into the nasal airway can cause severe anaphylaxis and also compromise the patient's airway. So it's not the most practical, but it is the gold standard. So in the clinical gold standard, therefore, is a skin prick test because it's relatively easy. It can be done in a safe manner. Of course, there are some contraindications, but the results are fairly straightforward. They come out, and it can also be a basis for you to treat the patient with immunotherapy if you required it. Yeah. So a skin prick test, okay, it is to identify specific allergens that trigger allergic rhinitis. Actually, it's more of allergic dermatitis, but because with relative certainty, you can tell that if the patient skin reacts to it, then the nose should react to it also. It's to confirm the Ig-mediated hypersensitivity. So how is it done? A small amount of allergen extracts are applied to the forearm. The skin is pricked with a lancet, and the results are read about 15 to 20 minutes later. What we actually read is the whale, larger than the negative control. There are some contraindications, like patients less than 3 years old. If the patient has had a history of severe allergic, if the patient had a history of anaphylaxis, then of course we would not put the patient through this skin prick test and use less invasive methods like RAST or PRIEST, which are blood tests, basically to look for IgE. IgE is specific to certain allergens. Okay, now what about sinuses? What about the sinuses? So usually for both allergic rhinitis and chronic rhinosinusitis, if the patient is first coming to us, we treat it very similar to how we treat asthma. We will do the test that is required, and then we will initiate treatment first. If the treatment fails, then we will proceed to investigating, like performing a CT scan. A CT scan is used, the indications are if surgery is being planned, because you want to see what are the sinuses that are involved, as well as look for certain anatomical variations that may be considerations surgically. Also, it maps out the extent of the disease, and it safeguards the critical structures during the operative period. It is also indicated in patients with complications of sinusitis. So sinusitis can lead to superimposed infections that can spread to not just the brain but also the eyes. Yeah. So this picture here shows air is black, gray is soft tissue, and white is bone. So this is what we actually look for, and this is the view that is particularly important to us, because at this area, remember where the polyps and the mucopus is where we pay the most attention to. So this it better, with a coronal cut, it better defines this area for us to pay attention to. Now this is also a CT scan of a patient, and you can see that the black is gone. So this is mainly filled with some sort of soft tissue density, which is isodense with the brain or even the eye. Of course, it's heterogeneous, which in this case would point more towards a fungal cause of the chronic rhinosinusitis. Again, just to impress upon everybody that there is a role for a CT scan in diagnosing patients with chronic rhinosinusitis, and not necessarily in patients with allergic rhinitis. Okay. So the treatment of allergic rhinitis is, of course, to avoid the allergens if you can. And then there is antihistamines, which are particularly important in the early phase, which we spoke about, and in intranasal corticosteroids and leukotriene antagonists, which will control more of the late phase symptoms. Immunotherapy, subcutaneous or sublingual. In Malaysia, I think there's sublingual, but it's very expensive, so it's not commonly done. And most of the patients respond pretty well to pharmacological therapy. And of course, there is patient education and lifestyle modification. So in terms of allergen avoidance, so the ARIA guidelines have released about 60 odd questions and question and answer format as to what a patient should do. For example, in order to reduce the effect of dust mites, they should use allergen-proof mattresses, pillow covers, washing the bedding in hot water weekly above 55 degrees, because this kills the dust mites, maintaining humidity if possible, and keeping the windows closed, using a HEPA filter in your HVAC systems, shower and change clothes after outdoor activities, keep pets out of bedrooms. But an interesting thing is they don't expect, like when a child of allergic parents are growing up, they don't recommend that you completely don't have pets. They recommend that you do have pets, but you introduce them to kids early. Yeah. And of course, fixing water leaks and reducing outdoor humidity. Again, allergen avoidance is a big topic, but generally speaking, the issue with allergen, with how much you're going to, at what lengths you're going to go to avoid the allergens, is a balance between your lifestyle and also some finances, because like HEPA filters and dehumidifiers are expensive propositions. Okay, so the treatment is again antihistamine, and nasal decongestion shouldn't be used for prolonged periods of time. Intranasal corticosteroids is still the mainstay treatment for moderate to severe, all the way to persistent severe. And immunotherapy is reserved for patients who are not improving at all despite maximal medical therapy. Okay, a little bit about sublingual immunotherapy. Its aim is to desensitize the immune system, giving daily drops or tablets under the tongue for a period of between 2 to 5 years. And this is done to progressively improve the patient's tolerance to whatever allergen the patient is first diagnosed to have. And again, this is based on the skin prick test or the RAST or PREAST, the blood test. For chronic rhinosinusitis, on the other hand, medical treatment starts off very similar. However, outflow obstruction is the main issue. So we try to clear that with nasal douches. Intranasal corticosteroids are aimed to reduce the inflammation around the areas which are causing the outflow obstruction. And if the patient has polyps, a trial of what is known as medical polypectomy is useful. It is basically the basis of medical polypectomy is to use an oral systemic steroid. And for approximately 2 weeks, this can be combined with an antibiotic and, of course, with the nasal douche and the intranasal corticosteroids. This is mainly used for patients with small polyps or patients with no polyps. However, if the patient does have extensive polyps, then this is usually not very effective and is instead used as an adjunct preoperatively in order to reduce the inflammation and the disease burden during the operation, which ends up improving the outcomes in terms of postoperative complications and bleeding. Okay, biologics. Okay, a lot of nowadays there's a lot of research that is going into it. So the goals of the surgery is to restore sinus ventilation and drainage, to remove the tissue and preserve normal anatomy and function, also to aid in the post-operative installation of the medications, which is particularly important. Now, just like the disease itself can cause injury to the intracranial structures in the orbit, the surgery in these areas can also lead to complications related to these structures. This is Prof. Prapagaran Narayanan. He's our head of unit for rhinology, and this was in Cape Town in 2018, where he was demonstrating the use of endoscopes in sinus surgery. And in this case, I just wanted to impress upon you guys, this was an image-guided system which can be used intraoperatively to map out the sinuses that need to be opened during the surgery. And this is the endoscopic view of the nostril. Of course, this is just the nose hair. Because if I showed you guys anything else, then okay, never mind. Adjunct procedures that can be done during chronic rhinosinusitis surgery is anything that is causing an obstruction can be addressed during the same time, such as if the septum is causing narrowing, then you can address that, or if there's the turbinates are causing it, then you can also do a turbinate reduction. Now, again, key differences between allergic rhinitis and chronic rhinosinusitis. The symptoms, as we have established, nasal block and running nose is as far as it goes. Anything beyond that it will either point to a predominant allergic component or predominant chronic rhinosinusitis component. We've also established the pathophysiology of both diagnostic tools like allergic testing as well as CT scans in CRS and the treatments that are available. So, some key clinical pearls. Allergic rhinitis and chronic rhinosinusitis, although they're different entities, can actually coexist. Although most of the time there's usually one component which is more predominant causing issues, whether it's sneezing and itchiness or it's nose block and facial pain. So when we don't diagnose which one this is, this often leads to patients being on prolonged periods of spray with not much improvement in their quality of life, which is what we aim to improve. Certain complex cases, it's best to be approached with a multidisciplinary approach. Accurate diagnosis requires a proper history and physical examination, which is particularly important in allergic rhinitis to identify what the patients are actually allergic to. Treatment should be tailored with the guidelines to guide us, however, should be tailored based on the patients. Again, paying important attention to where the patient is in terms of how they are exposed to allergens and how much they can, what their financial and their cultural or social cultural background is, so that they can adapt to reduce these allergens. Yeah. Thank you. So that's a gross overview. I hope I didn't confuse many people. The main take-home message is that most of the time when people come and tell you in Malaysia that they have sinus issue, or anywhere in the world that they have sinus related issues, they may actually be having allergic rhinitis, which is far more common. Yep. Okay. Thank you. Can stop sharing and open the.
All right. Thank you, Dr. Andrew, for the brief explanation about the allergic rhinitis and also chronic rhinosinusitis. Okay, anyone have any question to ask Dr. Andrew? If don't have any question, we may proceed to another presentation.
You have two Q&A, two questions in the Q&A box.
Wait, all right, let me have a look. Okay. All right, Dr. Andrew, we have two questions for you.
Okay.
The first one, the treatment can only control rhinitis or it can be cured.
Okay. Okay. Hi. Okay. So for control of rhinitis, because it is mainly a symptoms-based approach to the treatment, in order to the only probable cure is desensitizing. So when we desensitize a patient, in the meantime, we try to control their symptoms. But in the desensitizing, either occurs naturally as they try to avoid the allergens or reduce the effects of the allergens on their quality of life. And if there is an identified allergen that is either dust mite or something like animal dander, then if the patient is, for example, a pet lover, then the only cure for the patient would be immunotherapy, whether it is pharmacological immunotherapy or, like I said, desensitizing by exposing yourself slowly to these things. Okay. The other one is a lot of people said long-term use of corticosteroid will cause side effects. Is that true? Okay. The initial corticosteroids that we used was budesonide, and budesonide has got good effects. However, the systemic absorption of budesonide sits at about 7% of the spray. So that caused some concern in the earlier days. However, nowadays what we use is more Metason or Avamys, which is fluticasone. These two compounds are second generation or newer generation, and they've got a systemic absorption of less than 1%. Therefore, hitting a threshold where it causes systemic side effects is almost none. What about prolonged use of intranasal corticosteroids? Yes, this can, the two most common side effects for prolonged use of intranasal corticosteroids will be thinning of the nasal mucosa, which can predispose you to have bleeding, especially when you go to a place with a colder climate or a drier climate. And the other thing is that there's a slight increase of risk of getting fungal infections if in the future, for some reason, your immune system is compromised, even slightly. So these are the two main side effects that are associated with intranasal corticosteroids. Yeah, treatment of intranasal corticosteroids should be applied every day for lifelong or as per symptoms basis. Now, the main thing that we are trying to control here is the nasal symptoms. And two of the most commonest nasal symptoms are nasal block and running nose. Now, the nose has got a circadian rhythm when it comes to what is known as the nasal cycle in terms of how big the inferior turbinates or the middle turbinates are throughout the day, which also waxes and weans, and also the amount of mucus that is produced. With the use of intranasal corticosteroids, there is an irritant or there is something that is triggering an inflammation that is disrupting these changes within the nose. So we aim with intranasal corticosteroids to reduce the inflammation, thereby restoring the patient's normal nasal cycles when it comes to mucus production, as well as how big the inferior turbinates get. Once that is achieved, of course, we try to wean the patient off, and eventually we try to stop the patients on intranasal corticosteroids. However, if a patient requires long-term intranasal corticosteroids in order to maintain that relatively symptom-free lifestyle, then it can be considered. However, it should be done with close clinical monitoring. Yeah. Any other questions? Okay, hang on. What is the current best intranasal corticosteroid in the market? Well, it depends on which company you ask. Everybody says theirs is the best. But like I said, I think the active ingredient is the one which we should be discussing, whether it's mometasone or fluticasone. However, now with the third generation, there is an introduction of combining both intranasal corticosteroid and antihistamine, a topically introduced antihistamine at the same time. So when you spray with that particular spray, which I won't mention the name. Okay, I can mention the name, isn't it? Yeah, Dimista. So Dimista, when you use Dimista, the thing is that what I've noticed with my patients is that they have very rapid improvement, because the Dimista, the antihistamine, is aimed at the early phase of the inflammation that they get with allergic rhinitis, and the late phase is then controlled with the intranasal corticosteroids. Now, the only thing with Dimista is that it's a little bit bitter. So patients generally, so compliance becomes an issue because they don't want to taste that bitterness. It's almost like having a Panadol in the mouth, that bitter taste. So one way to go to circumvent that is to actually spray right before you eat. But Dimista, I think, would be up there in one of the good ones. Can polyps transform into malignancy? No, polyps generally cannot transform into malignancy. However, polyps can coexist with malignancy. For example, if the malignancy is causing an outflow obstruction, that can lead to some sort of chronic rhinosinusitis with polyps being there. Therefore, if a patient comes with polyps on one side of the nose, our suspicion as ENT surgeons goes up, because there might be something lurking behind it. But polyps by itself is not a tumor. It's not a pre-malignant condition. Okay. I think that's about it. Thank you, guys. Thanks everyone for your attention and the questions.
All right, we may proceed to another speaker if there is no more question for Dr. Andrew. Thank you from us, from ENT department. Thank you for giving time and listening to our talk. Thank you so much.